counseling students. Yeah, you don't have to worry about the bio case. I'm more than happy to discuss it with you when we do a lecture. So, okay, great.
Okay. Hold on.
I only see a piece of the slide, not the whole slide.
Getting there. Can you see better?
Better, thank you.
Got it? Okay, timely presentation. Okay, for everyone, I'm Sophie. I'm one of the first-year fellows. I'm going to be talking about solid organ transplant in pregnancy, since this has been coming up recently. So I'm going to start this topic through a case review. This patient is a 29-year-old G3P0110. She presented to us at 13 weeks and 1 day to our outpatient clinic for an MFM consultation. Her medical history is pretty complex, but most remarkable for a history of acute respiratory failure requiring baby ECMO in the setting of COVID-19, followed by a double lung transplant 4 months later. This was in 2022. Her transplant post-op course was complicated by a right hemothorax and empyema. She had paroxysmal AFib while admitted to the hospital, but is not currently taking anything for it. She also has a history of a provoked IVC thrombus following her transplant, for which she's not currently on anticoagulation. She is currently thrombocytopenic with platelets of 150 on her new OB labs. And she also has anxiety, as I probably would too. For her OB history, she has had 1 first trimester miscarriage, followed by her second pregnancy. That was her last pregnancy, a stat mid-transverse primary section for fetal bradycardia following emergent intubation during her COVID admission. Her neonate very sadly died after delivery at 24 weeks and 6 days. For her surgeries, she's had her cesarean, she's had a double lung transplant, followed by multiple bronchoscopies and a VATS decortication, as well as a mediastinal exploration for her empyema. She denies any history of abnormal pap smears, and her last one was in September of 2023. She's currently on multiple medications for immunosuppression. She's on tacrolimus, azathioprine, and prednisone. For pneumocystis prophylaxis, she's on Bactrim. For antifungal prophylaxis, she's on posaconazole. And to reduce the risk of chronic allograft dysfunction, she's on azithromycin 3 times per week. For her anxiety, she's on sertraline. For her genetic screening, she's not yet completed any NT scan or had any maternal serum testing, although an NIPT and carrier screening was ordered by her outside provider before she was referred.
Do we think we'll talk about that?
I'll talk about it too.
I love it.
Yeah. So some more of her relevant history. Her last chest x-ray was in September and was stable from her prior imaging without any signs of infection. Her childhood vaccines have been completed in addition to shingles, a meningococcal series, as well as part of her pneumococcal series. Her last pulmonary function tests were in September as well, where her FEV1 and FVC, we'll go over those, were at her post-transplant best. The infectious disease profile for her donor lungs, which we'll also go over more later. The donor was negative for CMV and toxo and positive for EBV. These are some of her pulmonary function tests. I'm sorry, the quality is kind of low, but these are in graphical form. So this is her spirometry trend for each date. And this is starting at her first spirometry after transplant until her most recent one over here. And you can kind of see that she's stabilized. This kind of provides us with an idea of her post-transplant baseline. The pulmonary tests listed above are displayed graphically here, and then you can see the patient's forced vital capacity and forced expiration volume in 1 second is diminished by her PFT graphics. That's here. Been a while since we've all looked at those. So I'm going to start with just some history and general information regarding transplant in pregnancy. So the first successful pregnancy after solid organ transplantation occurred in 1958 and was reported in 1963 by Murray and colleagues in a woman who had a renal transplant. The first pregnancy following a liver transplant was reported in 1976. The first pregnancy following a cardiac transplant was reported in 1988, and the first pregnancy reported after a lung transplant was in 1992. Pregnancy after transplantation is becoming increasingly common as the rates of transplant and reproductive age women are also increasing. Over a 10-year period, the number of reproductive age women who receive transplants has increased from about 3,400 and change to 3,700 or 4,700 and change. And these numbers are over a 1-year period. Additionally, children who receive organ transplants are living longer and they're able to reach childbearing age and are now becoming pregnant.
Coming to Dr. Green.
And coming to all of us. So this is some really interesting data. So this is descriptive data. It is published in 2024 from the Organ Procurement and Transplantation Network and Scientific Registry of Transplant Recipients. Their data includes US national data, and currently their report includes 2012 to 2022 data regarding solid organ transplant. So it's a really impressive, publicly available 600-page retrospective report, and it's published every year. The figure on the left is the total counts nationwide of kidney or liver transplants with multi-organ transplants and retransplants included. So the year is on the x-axis and the number of transplants in thousands is listed on the y-axis. You can see generally the frequency of both liver and kidney transplants are increasing here. The figure on the right is the total counts of transplants for organs other than isolated kidney or liver, and you can see that the rates of heart and lung are generally increasing. Those are here, heart and lung here, whereas the rates of intestine and pancreas alone are generally staying the same. Those are here and here. So I just want to take a second to introduce the Transplant Pregnancy Registry International, a TPRI, because I'm going to be referring to a lot of their data throughout this presentation. So this International Pregnancy Registry, it's a great opportunity for all of our patients to contribute to this small but growing body of knowledge and data regarding pregnancies affected by solid organ transplant. Because this is such a rare occurrence relative to other pregnancy outcomes, there are really few large prospective studies out there. And this registry has really helped to better understand, to help increase our understanding of pregnancy outcomes in the setting of organ transplantation.
You know where it was started, right?
Nowhere. Here?
Yeah.
Oh, sweet.
Yeah, it was started at Thomas Jefferson University.
I didn't know that.
Vince Armenti used to be one of the transplant surgeons. And they used to have a whole suite with several research nurses, et cetera. Then lost his funding and things like that, but thank God other people are continuing. But the first, 20 years, it was all Jefferson led. Yeah.
Amazing.
Yeah.
Well, here it is. Thank you, Dr. Briella, for that important piece of history.
Yeah.
So it currently contains information for over 3,500 pregnancies affected by all kinds of allografts. So for our patients, this is taken directly from their website. To participate, they need to have had a post-transplant pregnancy, really of any kind, and it doesn't matter what the ultimate outcome is. Their participation involves filling out a consent form online and then interviewing periodically with one of the research coordinators. And then if they want any additional information, it's really all available on their website, but we should be encouraging all of our transplant patients to participate in this registry. So here's a quick overview of the talk today. We're going to start with pre-pregnancy counseling and then move into intrapartum management with specific maternal and fetal risks of pregnancy. discuss antenatal surveillance, monitoring of allograft function, and the timing and route of delivery. And then I'll go over some organ-specific considerations by transplant type, and then we'll finish with postpartum management of immunosuppressive therapy, and then some contraception as well. Start here. So both SMFM and the American Society of Transplantation recommend pre-transplant counseling and pre-transplant and pre-pregnancy counseling as part of the whole journey of taking care of these patients. This counseling should involve a discussion of fetal and maternal risks and pregnancy outcomes after transplant, including the risk of obstetrical complications and the impact of pregnancy on allograft function. The recommended timing of pregnancy after transplant should be discussed, which kind of depends on the kind of transplant, and contraceptive counseling and management are recommended to facilitate appropriate pregnancy timing and reduce the risks of adverse pregnancy outcomes or rejection. This is a pre-pregnancy evaluation checklist. So patients should have a consultation with MFM, as well as transplant surgery and organ-specific subspecialists. When we see them in our office, it is our responsibility to make sure that they are plugged in with the right people. In addition, we should take a detailed pre- and post-transplant history, including episodes of acute rejection or potentially fetotoxic infections that they've had recently since becoming immunosuppressed. We should take a comprehensive medical history and try to elucidate any medical comorbidities and indication that might have been their indication for solid organ transplant. We should go over their current medications in detail, including their maintenance immunosuppressive regimen, and assess stability of this regimen and identify any potential teratogens. We should assess their vaccination status and provide or recommend any indicated vaccines, which I'll go over. All patients should have a complete physical exam, and you should note specifically any implants or incisions that they have that differ from our normal patients without transplants. We should obtain baseline labs and studies, which I'll go over more in detail, and we should evaluate their psychosocial needs and involve psychological and social support services as they're needed. So first we'll go over timing of pregnancy. SMFM recommends deferring pregnancy for at least 1 year following transplant in all patients, except for individuals with a lung transplant, in which case deferral for 2 years is actually recommended. We recommend that pregnancy is deferred for 1 or 2 years following any episode of acute cellular rejection as well. SMFM also recommends that individuals with a solid organ transplant have stable allograft function and optimal control of their chronic medical comorbidities before attempting pregnancy, because the pre-pregnancy allograft function is really the critical factor that guides counseling for our transplant recipients who are contemplating pregnancy. Of course, other mitigating circumstances should be taken into consideration, including the etiology of their original disease leading to transplant, any evidence of chronic graft rejection, medical comorbidities, including hypertension, diabetes, obesity, inherited diseases and genetic considerations, and then maternal viral status as well. So why are the lung recommendations so different? In general, the rates of survival are much, sadly, lower in lung transplant patients when compared to other solid organ transplant patients. This is because the graft is considered to be in a chronic rejection state because it's exposed to the environmental air, whereas other types of grafts are not receiving that same chronic exposure and hits against them. I think this data is really helpful to know for our patients who are planning pregnancy, that the rates of recipient survival are also much lower when you compare it to a more commonly seen and studied transplant, such as the kidney. So these graphs are from the OPTN, the Organ Procurement and Transplantation Network, that I referred to earlier. So the top graphs are for kidney, and the bottom are the same graphs but for lung. So the top graph on the left is the patient survival by percent by year post-transplant. amongst kidney transplant recipients. And then the same graph for lung transplant recipients is below. And you can see that even at about 1 year post-transplant, nearly 100% of kidney recipients of reproductive age are living, whereas only 90% of reproductive age lung recipients are living. And that number decreases really every year for lung. And these graphs just notably are not stratified by gender, but you get the gist. The graphs on the right demonstrate the rates of acute rejection by 1 year post-transplant. So the top is for kidney recipients and the bottom is for lung. The purple line is the 18 to 34-year-olds. That's the age of most of our transplant recipients. So in 18 to 34-year-olds, the rate of rejection within 1 year of kidney transplant hovers around 9%. Whereas the rate of rejection in the same cohort in lung recipients is around 16% until COVID hit, which is like right here. Yeah. So this is moving into immunosuppressive therapy. So immunosuppression is really vital to the health of the transplanted organ. And the patient must be continued on these medications throughout pregnancy to maintain adequate graft function and prevent rejection. The mainstay immunosuppressive therapy includes calcineurin inhibitors, which are cyclosporine and tacrolimus, anti-proliferative agents like mycophenolate, azathioprine, and sirolimus, and then corticosteroids. Mycophenolate works by inhibiting purine synthesis, which you can imagine would be very problematic for a developing fetus. It is a known teratogen, and due to its half-life, we recommend that it be discontinued 6 weeks prior to pregnancy. Typically, patients are put on mycophenolate infusions immediately following transplantation, and then they're transitioned to oral mycophenolate on discharge from the hospital. Once they're contemplating pregnancy, they're usually very quickly switched to azathioprine if they're able. Go ahead.
So this contraindication happened only the last few years. It's always good to know the history. I probably had patients on it for many, many years before, the FDA came and said, you don't use it anymore. So I've used it for more than 10 years before it was banned, basically, just to teach you some of the history.
So do you feel like you saw embryopathy as a result?
I didn't see one, but of course, our numbers are not gonna, it's the FDA, they're gonna have much larger numbers. But I'm telling you how things change. That's why you have to stay up to date, and typically the FDA will send you mail, you get mails about medications, they know you're an OBGYN, they're gonna be sending you things that your specialty to stop using, black box or something like that, so, yeah.
Another important thing to know regarding immunosuppressive therapy is that tacrolimus is a CYP450 dependent medication, and it's also highly bound to albumin and erythrocytes in the maternal serum. Thus, with the maternal serum volume expansion that occurs in pregnancy, dilutional anemia, and decreased albumin levels, the doses of tacrolimus typically need to be increased by 25 to 30% throughout pregnancy to maintain our therapeutic level. And then finally, sirolimus and everolimus have conflicting data about congenital malformations in pregnancy, so their use is not generally recommended, and we recommend discontinuation 12 weeks prior to pregnancy due to their very long half-life. Some other key points with immunosuppressive therapy. So a patient should essentially not ever be on mycophenolate, which is a change from history. Ideally, a pregnancy safe and keyword stable regimen should be established prior to conception. The physiological changes of pregnancy, including increased plasma volume, changes in protein binding, increased hepatic activity of the cytochrome P450 proteins, delayed gastric emptying with slower bowel transit, and increased GFR often lead to subtherapeutic immunosuppressive drug levels, especially in drugs like tacrolimus. And so this necessitates the dose increase throughout the course of pregnancy. Like I said, the tacrolimus is really sensitive to this, so their serum levels are typically followed at a minimum of every 4 weeks during pregnancy. increasing to about every 1 to 2 weeks once you're beyond 32 weeks, and then within 1 week postpartum to have postpartum adjustments. And we should anticipate that these drug doses become lower almost immediately postpartum, but we typically defer these adjustments to the transplant team. So this slide is for Dr. Al-Khwali. Just want to make sure you guys can see all my references here. So the, there we go. Okay, so I'll touch on some of the genetic disorders that could possibly be an underlying etiology behind maternal transplant. So this is not an exhaustive list at all, but I just wanted to highlight some of the ones that we could more commonly see by organ. So when a genetic etiology is known or suspected, the patient and their partner should absolutely be referred to genetic counseling, ideally pre-pregnancy, but if not, then early in pregnancy. Some possible genetic etiologies behind a renal transplant may include autosomal recessive polycystic kidney disease, Alport syndrome, FSGS, which I didn't realize can have an adult or childhood onset, and has a genetic component with variable penetrance. Potential genetic liver etiologies include alpha-1 antitrypsin, Alagille syndrome, Byler, which is progressive familial intrahepatic cholestasis, as well as Wilson's disease and maple syrup urine disease. Potential cardiac etiologies. Cardiac genetics seems like a whole other world, but essentially all of the genes that are related to various forms of cardiomyopathy, which are kind of divided here by the kind of cardiomyopathy that you might encounter early in life. Potential lung etiologies include the most common for our potential patient population, which is cystic fibrosis, alpha-1 antitrypsin, and then this really interesting lymphangioliomyomatosis, which is very rare but can occur in association with tuberous sclerosis complex.
This is really an amazing slide, and thank you for bringing these genes together. I can't believe it. Did you guys see like she even made the spelling, not only the spelling of the genes, you know, you formatted them accurately, which is fantastic. So I'm sure many of us like cover the ICU, and then you called in, oh, this patient, you know, as residents, as fellows, having done this like many, many times, you know, this patient is undergoing a cardiac transplant. And then as you go more and more in the field, really, this patient who's having a cardiac transplant, like, so why is her heart failing? And really investigate this, unless you have someone who's like strong in genetics, who's gonna ask the question, why did she have the hereditary cardiomyopathy, right? Why did she have that restrictive? So basically there's a lecture on each type of these with multiple genes involved. And there are people who are like passionate about these the same way I'm passionate about prenatal genetics.
Yeah.
So this is amazing. One of the common thing which I noticed is the alpha-1 antitrypsin, because as you could see, it affects the dual organs. It can affect the liver, it can affect the lungs. This is one of the diseases. If you forget most of the slide, you know, maybe it's good to remember your alpha-1 antitrypsin deficiency.
Absolutely.
Thanks.
Yeah, I learned that from Stephanie, that cardiac genetics is a subspecialty of its own. And if you feel like your patient warrants a workup, that is something you can refer them to, much like cancer genetics or genetics. So we'll move on to vaccinations. I limited this slide to vaccines that we typically counsel on in MFM and OB. So it's important to remember that transplant patients cannot receive live attenuated vaccines once they are post-transplant because they are immunosuppressed. So if a patient is rubella non-immune, then they should receive an MMR prior to their transplant. Because of their immunosuppression, transplant patients should receive the pneumococcal series and the meningococcal series. And if it's not already received, this can be completed safely during pregnancy. Our normal third trimester vaccines are safe to administer. And then postpartum, we should recommend an HPV vaccine series and the Shingrix vaccine, as long as the patient is over 19, if they're not already received. And then I think this slide. I hope Sarah is listening. This slide is for her. Because transplant patients are immunosuppressed, we have some special infectious disease considerations. Patients who become pregnant within the first year following a transplant are at the highest risk for developing infection and reactivation of a latent infection, which might lead to perinatal transmission. So the most common opportunistic infection that we see in a transplant patient is cytomegalovirus or CMV. So much so that donor and recipient serologies, as I mentioned in our case in the beginning, are tested ahead of time to help guide recipient prophylaxis. So valganciclovir is used for CMV prophylaxis for a duration of 200 days if the donor is positive and the recipient is negative, or 100 days if the recipient is already positive. If both the donor and the recipient are negative, then only acyclovir is commonly used, and that is just to cover for herpes simplex virus or HSV prophylaxis. And seeing as valganciclovir would have covered both, and that's why you don't need acyclovir for the other ones. So it's generally recommended that patients complete this prophylaxis prior to conception, and most patients do with their interpregnancy interval. But it is something to look out for in case someone does become pregnant before the recommended time period. It's important to note that there is no high quality data to guide our duration and frequency of CMV monitoring, and that the real ideal pregnancy timing following a CMV infection in transplant patients is unknown. And then currently routine repeat screening for CMV is not recommended in pregnancy. So to wrap up our preconception section, how should we best counsel our patients on the risk that pregnancy poses to them as a transplant patient? So lots of data on this, especially with kidney and liver patients. So based on several studies comparing transplant recipients who become pregnant with those who were never pregnant, long-term survival does not seem to be impacted by pregnancy as an independent risk factor. But rather, the variation in life expectancy that we see in transplant patients is most affected by organ transplant type, the age at transplantation, and the indication for transplant. But how should we best counsel our patients on the risk that pregnancy poses to their allograft? This answer is like a bit more nuanced. There are numerous physiologic changes that occur in pregnancy that may impact graft function. These include increased cardiac output, expanded blood volume, decreased systemic vascular resistance, increased GFR, a decreased albumin, and increased clotting factor production. That said, in general, when a person becomes pregnant with an allograft, the graft is most likely to maintain normal function throughout pregnancy. The exception to this is in the case of pre-existing graft function or rejection. I think that is best highlighted by the inpatient case that we saw. If that is present prior to pregnancy, then graft deterioration or loss is far more likely to occur. So the general rule is stable in is stable throughout. It is important to counsel our patients that in the unlikely case that graft rejection is suspected or occurs during pregnancy, that one, signs of graft rejection can look like other pregnancy-related problems and can be difficult for us to distinguish sometimes. And two, if acute rejection occurs, the treatment options are very limited. So now we're going to move on to intrapartum management, starting with specific adverse outcomes that our transplant patients are at an increased risk for. This section is very meaty. Okay, so the rates of hypertension and preeclampsia amongst individuals with a solid organ transplant are significantly higher than the background rates of chronic hypertension, which is about 2%, and preeclampsia, which a background rate is about 6.5% in the general OB population. So patients with a kidney transplant, the overall incidence of preeclampsia is about 20 to 30%, which is 6-fold higher than the general population. And the incidence of chronic hypertension is very high, depending on what you read, somewhere between 50 and 80%, with about 50% of those requiring medication during pregnancy. So as you can see, across all 4 main transplant types, we encounter higher rates of chronic hypertension, preeclampsia, and gestational hypertension, all above the background rates. The figure on the right here, this is included in the SMFM practice bulletin on solid organ transplant, and it's originally from a review article published in July of 2021 by Kalapur et al. And their colleagues from UCLA in an article titled "Pregnancy Care in Solid Organ Transplant Recipients." It's a really great review article. The graph demonstrates the adverse outcomes on the x-axis and the prevalence on the y-axis. The black line in each of these represents the background risk, and the colored lines are specific for each transplant type. So for here, I sort of shaded the gestational hypertension and preeclampsia. Gestational hypertension is most prevalent in lung transplant recipients, followed by renal, and least common in liver. And then pre-E is most common in renal and least common in lung.
At least common, still the percentage, let's say for the
Still
liver,
is
it's like 20%.
very high, yes.
So really,
Much higher than our background rate.
Exactly.
Yeah.
So just remember that, because I've
Yes.
had also many cases who had liver transplant, and then it's the preeclampsia.
Yeah.
We didn't know that early on, like more than 20 years ago, when we were dealing with these patients. It was some unusual for us.
Yeah. So these tables are from that review article that informed that graphic on pregnancy care and solid organ transplant recipients. So this first table is comparing outcome data for kidney transplant recipients from two registries and 2 meta-analyses. So this table, it kind of goes over the outcome and then the rates quoted depending on what study you read. They're highly variable, as you can see, just because this is not really a common thing to encounter. And then this table is similar, but for liver transplant recipients. They compare data from a single site study, that's here, and then a meta-analysis here, and then the NTPR registry. Just so you know how that graph was created and what information went into it. So speaking of hypertension, how should patients with renal transplants be counseled on aspirin use during pregnancy for prevention of preeclampsia? I wish Dr. Bullock was on. So I'm going to talk about dose.
That's for Dr. Bullock.
Yeah. So 2 major studies that looked at aspirin use, notably in non-pregnant patients following kidney transplant, demonstrated that aspirin is at least not dangerous and may even improve renal function. So as I said, these studies were not done in pregnant patients, and then the dose differs from our current recommendation of 81 milligrams. The aspirin dose in this second study ranged from 75 to 150 milligrams a day, and the most frequent dose used included in this review was 150 milligrams a day. But because of all of this data, we do recommend daily low-dose aspirin prophylaxis to reduce the risk of preeclampsia in pregnant individuals with a solid organ transplant, because we think it's safe, and to reduce the risk of renal allograft failure in renal transplant recipients.
Is that mentioned in the the task force?
Okay, management of preeclampsia. So management of preeclampsia can also be tricky in patients with transplant for a few reasons. The first reason being that acute rejection can mimic preeclampsia, particularly in our renal transplant patients. And second, transplant patients with severe preeclampsia prior to 34 weeks were not included in the original trials regarding expectant management of preeclampsia to 34 weeks. There is really little data to guide delivery timing and when the risk to the allograft starts to outweigh the risks of prematurity. One of the largest studies to date examining the long-term outcomes in women with kidney transplants with and without preeclampsia was done by Van Avel et al. I think it was out of Mount Sinai, published in the Green Journal in 2018. That's here. So they performed a retrospective cohort study. They included 52 women total. and found that the incidence of graft loss and decreased kidney function up to 2 years postpartum was similar between groups, women who had preeclampsia and women who did not. So their definition of preeclampsia in this study, because they looked back for many years of retrospective data, was new onset or significantly worsening of hypertension in combination with other signs of end organ damage or severe fetal growth restriction. Just to give you an idea of their data, so 12 of 20 patients with preeclampsia were delivered prior to 34 weeks, and 19 of 20 were delivered prior to 37. So this brings me sort of to timing of delivery in patients with preeclampsia in the setting of a transplant. Due to this study, there is some evidence to support the safety of expectant management of patients with pre-E without severe features to 37 weeks. But for early onset severe preeclampsia, the safety data is really lacking, and we should have a lower threshold for preterm delivery to preserve the allograft function. We'll move on to preterm birth. So the background risk is about 10%, and in order of highest to lowest preterm birth rate amongst the allograft groups, lung has the highest, but I would say they also arguably also have the least amount of data. Followed by kidney, which ranges from about 37 to 52%, and they do have the most robust data. Cardiac has a really wide reported range, and it's variable depending on what studies you include, but it hovers somewhere between 40 to 50%. And liver has the lowest rate of preterm birth, relatively ranging from 27 to 40%. You'll notice on this graph that the trends in preterm birth are similar to the trends in hypertension between transplant groups. And indeed, most authors looking into this data speculate that medically indicated deliveries, particularly those related to hypertensive disorders, represent the most common etiology of preterm birth amongst transplant patients.
I guess this is a good slide. I don't want to interrupt, but to say which one would you rather, when you have a transplant patient coming, which one, what would you take? What's the easiest one to handle?
Which one would I want?
Yeah.
Liver.
Yeah, I mean, by far,
By far.
So livers do so well, and next.
Kidney.
Yeah, probably, even if, depending on the creatinine, we saw this lady,
Yeah.
Hopefully somebody with a kidney who's at low creatinine.
I think it's a hard choice between heart and lung after that. Both sound terrifying to me.
But which one do you think is a little bit worse? Based on the data you're presenting.
I think probably lung.
Yeah.
They have the worst outcomes.
Yeah. That's worse outcomes.
So just a quick slide on FGR. So the background rate is about 10%. There's not a lot of studies outside of renal transplant that had FGR as a primary outcome, but the rate of FGR in renal transplants is about 20 to 30%. The rate of low birth weight is likely attributable to the high rates of preterm birth, as you can see here. In this table, this is from the SMFM practice bulletin with data from the 2020 TRPI. So this is, I'll draw your attention to low birth weight here, mean birth weight here, and then late preterm delivery here, and then we'll go over these tables in more detail later. But you might also notice on this table the rates of neonatal death, that's here. These are also elevated among the background rate. So the background rate is about 1 in 6,000, whereas for these patients it's about 1 in 500. The etiology is not really definitively clear, but it's thought to be related to an increased risk of preterm birth and then these maternal comorbid conditions, especially for lung.
Just odd that it's that high because the mean gestational age at delivery is still 34 weeks, which is an excellent gestational age.
Right.
So it's just,
It's
substantially.
There's not a great explanation for it either in the practice bulletin.
Part of me wonders how much of this is people aren't waiting the full 2 years and they're coming in not stable and not
Yeah.
And also 35 patients compared to like
Right.
1,700.
That's
Yeah,
a
like there
smaller.
should be like an asterisk on all the lung data. It's just really limited. There's
Yeah.
just not a lot of these patients.
So you're lucky you're seeing a patient with lung transplant during your fellowship.
Yeah.
That's a dream for a fellow.
And I suspect there will be more now that we're getting into the 2 years post-COVID transplant lung patients. So
Sadly, this patient is going to Penn just because that's where the lung, like,
I know.
they have an established lung transplant team, but we at least got to see her for a consult.
just a quick note about psychosocial support. So transplant patients are pretty familiar with their own morbidity and mortality. They have an awareness of their overall health status, and this is often it often leads to a higher rate of depression and anxiety. And we should offer these patients psychosocial support early and often throughout pregnancy, and screen them early for postpartum depression as well. So as we just reviewed, there's an increased risk of both adverse maternal and neonatal outcomes. There's a need for increased antenatal surveillance of these patients. SMFM recommends serial growth assessments every 4 to 6 weeks. At Jefferson, and I believe I was referencing the most recent guidelines for this, for someone complicated by only solid organ transplant, we recommend a growth ultrasound every 4 weeks, starting at 28 weeks. SMFM also recommends antenatal surveillance starting at 32 weeks, but it does not dictate a frequency. And unless I missed something, there is no specific NST recommendation for solid organ transplant alone for our current guidelines. There are NST categories that would likely capture most, if not all, of our transplant patients, though, namely those with a creatinine over 1.4 and other medical comorbidities, and those with comorbid hypertension. But there is not one just for transplant alone. Just a note about cell-free DNA screening. So in this population, there is a potential for interference from the allograft because sex discordance between organ donors and recipients is real. This could theoretically impact the fetal sex chromosome analysis. You can always send an NIPT and forego the gender if you would like to take that out of the equation altogether. There is no contraindication for amniocentesis and chorionic villus sampling for these patients because of medical immunosuppression. So that procedure can be offered as clinically indicated and appropriate. So how should allograft function be managed during pregnancy? It should be assessed pre-pregnancy to help guide our counseling, and then again on confirmation of an intrauterine pregnancy. And from there, about every 4 to 6 weeks throughout pregnancy, increasing to every 2 weeks, 1 to 2 weeks beyond 32 weeks. Graft assessment varies by type of organ and by concern for rejection or dysfunction. So for example, a baseline assessment of a cardiac graft should include a chest x-ray, a cardiac cath, and or an endomyocardial biopsy, but these are not typically repeated unless clinically indicated. For lung, chest CT and bronchoscopy may be considered as part of the baseline clinical assessment for lung function, but they're not routinely repeated in pregnancy unless clinically indicated. So the more routine way to assess a lung graft function would be with an oxygen saturation at every visit, and then pulmonary function tests at varying frequencies. So the right column here lists some common signs of graft dysfunction per organ. Especially for lung and heart, because I really haven't taken care of patients with lung and heart transplants. I really wasn't sure what a lung rejection looked like, honestly, or what a cardiac transplant rejection might look like. And it turns out that one is a little more complicated than it seems. For timing of delivery, so this is often dictated by the patient's other comorbidities, and about 50% of all patients with solid organ transplants are delivered preterm. Typically, this is dictated by the patient's hypertension, but the decision of when to deliver these patients is really highly individualized. If the patient is part of a small group of patients that has no additional complications, then they can be reasonably considered for delivery anywhere between 37 to 39 weeks. just due to their increased risk of developing hypertensive disorders in pregnancy at term. What is the best route of delivery for transplant patients? There's good evidence for at least liver and renal transplant patients to suggest that allograft loss is not associated with mode of delivery, so it's reasonable to reserve cesarean delivery for OB indications. It's important to remember that immunocompromised individuals are at increased risk for post-op complications like surgical site infections and delayed or impaired wound healing. Despite this general recommendation, you can see the rates for the TPRI data of 2020 of cesarean delivery remain high across the board for transplant patients, and this is likely due to their many comorbidities and increased rates of preterm birth.
Just Lisa Kosha, maybe she's been kind of the one who's done all the work, you know, as a nurse. And Michael Moritz used to be a transplant surgeon at Jefferson, but you know, historic, and it's the you know, that's the biggest registry by far. Yeah.
Some additional delivery considerations. So patients who receive a steroid dose equivalent to over 10 milligrams a day of prednisolone as part of their immunosuppressive therapy will need to be considered for stress steroids if they have a cesarean delivery. Postpartum, our patients should have close follow-up with the transplant and organ-specific teams for adjustment of their immunosuppressive meds back to pregnancy baseline or pre-pregnancy baseline. And then we should assess their desire to breastfeed, as this may dictate their immunosuppressive regimen postpartum. As far as anesthesia goes, management in these patients is overall the same, aside from important differences in drug metabolism, which we've discussed, and special concerns for cardiac transplant patients, which I'll get into the specifics in a bit. But these patients really need pre-delivery anesthesia consults to see if a cardiac anesthetist should be involved in any potential surgery. As far as surgery goes, for renal transplant patients, you're very unlikely to encounter the pelvic kidney or injure it or the ureter during any cesarean. However, it is good practice to involve the transplant team early because they usually want to be there. This is a picture demonstrating the differences in anatomy between the patient's native kidneys, which are up here, and then the allograft kidney, which is typically implanted, not retroperitoneal, in the pelvis.
I think I would still be careful, you know, all of us have seen residents do sections and they're putting their entire weight on the abdomen, so.
Yeah, I mean, most people will open with transplant. Transplant surgeons, I think, have a generally want to be very involved in all of their patients' care, especially when it comes to surgical care.
At Jefferson, but you may leave this place and they may not want to be there. I've operated on these patients without a transplant person.
But in general, you are very unlikely to encounter the kidney and injure it with the type of incision that we make, as long as everything goes well.
Yeah.
So I'm gonna quickly review the most important considerations for transplant patients based on their type of allograft in this next section here, starting with the kidney. So some general predictors for the kidney of poor pregnancy outcomes to remember: uncontrolled pre-existing hypertension, elevated pre-pregnancy creatinine over 1.4, nephrotic range proteinuria, a GFR less than 30, and then a history of 2 prior transplants. All of these bode very poorly for somebody entering a pregnancy. The blood pressure goals are sort of in line with our CHAP trial goal of less than 140/90, although I don't think they included transplant patients. The recommended blood pressure target for patients with renal transplants is 130/80, based on the Kidney Disease Improving Global Outcomes clinical practice guidelines. So SMFM aligns with these guidelines and recommends that we aim for a blood pressure goal in chronic hypertension with a kidney transplant of 130/80. These patients are also at an increased risk of UTIs, as high as 42% by one study in pregnancy. Thus, monthly cultures are indicated with treatment if positive, but there is no current evidence for daily suppressive therapy. Renal biopsies should only be considered if they will change management, since there is some evidence to suggest that there are significantly increased risk of complications with intrapartum biopsies compared to postpartum. And then last, NSAIDs should be avoided in kidney transplant patients as they are associated with an increased risk of AKI. And if they must be used, they should be used for the lowest effective dose, at the lowest effective dose for the shortest duration possible. These are just tables from the SMFM practice bulletin highlighting the DPRI 2020 maternal and birth outcomes. So I've highlighted the information specific to renal transplant, and you can see that it's the most commonly performed transplant. There's the most amount of data in pregnancy. The rate of allograft rejection is about 3%, which is the lowest compared to all others. The other outcomes we sort of talked about already. I'm going to talk a little bit about pancreas kidney transplantation. So this is typically performed in patients with diabetes requiring insulin with advanced or chronic end-stage renal disease. In the United States, nearly 90% of pancreas transplants are performed simultaneously with kidney transplants. In general, their outcomes are really similar to that of kidney transplant patients, so they're managed similarly. Just a quick note about diabetes in this population, is I remember being confused about this the first time I encountered a pancreas transplant. So although diabetes was likely a diagnosis that they carried prior to transplant, unless it was again diagnosed after transplant, the patient does not in fact have diabetes anymore. So they still need to be screened for gestational diabetes per normal ACOG guidelines. Pregnancy outcomes in individuals with a pancreas kidney transplant and kidney only transplant are relatively similar, so they both have high rates of preeclampsia, prematurity, and cesarean delivery. Less data than kidney alone. So for liver, characterization of the underlying condition is really key to understanding their recurrence risk. So things like hepatitis B and C infection, primary sclerosing cholangitis, autoimmune hepatitis, hemochromatosis, alcoholic liver disease, and hepatocellular carcinoma can recur even in the transplanted liver. So liver transplant patients are also at an increased risk of ICP or intrahepatic cholestasis compared to the general population. But there is no role for asymptomatic bile acid screening in this population. Some things to know about graft loss. Patients are more likely to have graft loss within 5 years postpartum if they had their transplant young, if they had an episode of rejection during pregnancy, or within 3 months postpartum. In general, recipients of liver transplants tolerate pregnancy better than any other individual with a solid organ transplant. They have a lower incidence of hypertension and preeclampsia than individuals with a kidney, pancreas transplant, heart, and lung transplants. Their infants tend to be born closer to term, and then they have higher mean gestational age at delivery than other recipients, and they have a lower incidence of maternal hypertensive disease. So that is why I would pick a liver transplant patient.
It's like a weird would you rather.
I know. Moving on to heart. So the most important thing to know about a cardiac transplant is that they essentially act very differently than a normal heart. And I 1000% did not know this before making this presentation. So this all stems from the de-innervated cardiac allograft. So heart transplantation surgically interrupts the parasympathetic vagal neurons and the intrinsic postganglionic sympathetic nerve fibers that travel to the myocardium. So this impairs the whole normal reflex responses of the cardiopulmonary system. This leads to an intrinsic cardiac heart rate of 80 to 100 beats per minute. They have a delayed or blunted stress response. They have an increased frequency of arrhythmias. They're very preload dependent. They operate on the Starling curve, which I had completely not thought about for a long time. And their cardiac output is maintained by their stroke volume because their heart rate is a consistent factor. whoa.
Ideal for
and they're-
hemorrhage risk,
Right?
So
So
pregnancy
crazy.
and cardiac transplant patients.
It is stable, like it is that, it is that,
Really?
yes.
Because it's not
Because
responding
it's not
to like
responding to
decreased
normal physiologic cues.
systemic resistance.
Yes.
It's really bad.
Isn't that crazy?
I haven't taken care of a patient with cardiac transplant, please, refer someone for me.
They also can have silent myocardial infarction.
That's terrifying.
Which is so crazy. And then they're also, one of the signs of graft rejection is accelerated atherosclerosis, which I also didn't know, like this totally different. So how can we actually like take great care of a cardiac transplant patient? It really does start with a thorough pre-pregnancy assessment. So it should include things that, you know, we would normally think of like an EKG and an echo. But most patients are also considered for a cardiac MRI, and this is to assess for graft vasculopathy. And then if there is significant vasculopathy, which is not up to us to interpret, but we should discourage or delay pregnancy because that can be a sign of rejection. So in delivery planning, we should have a multidisciplinary approach with members of cardiology, cardiac anesthesia involved. Because the graft is deinnervated, they also don't have a normal cough reflex sometimes, and this can put them at an increased risk of aspiration during intubation, like all these things. I did not know this. We should consider minimizing Valsalva within operative delivery. Patients should be on continuous telemetry. Speaking of keeping them safe, so subacute bacterial endocarditis prophylactic antibiotics are usually only given to patients who have hardware within their hearts or an abnormal valve. And that is true for transplant patients as well. So the American Heart Association doesn't recommend routine SBA prophylaxis at time of delivery, no matter what the route, unless there's a structurally abnormal valve in the graft. It's also important to remember that the underlying etiology of the patient's transplant is important. So if it's congenital in origin, like the patient had a complex congenital heart disease and now has a transplant, then a fetal echo should be ordered. It's also good to know that the 5-year survival rate for female cardiac transplants recipients is only about 76%. And this number does not seem to be affected by pregnancy. Mm-hmm. So this is the TPRI data for cardiac patients. They have rates of hypertension and pre similar to that of kidney recipients. And then their rate of graft rejection in pregnancy is about 8%.
Surprised the cesarean delivery isn't a little higher, just given like contraindication to Valsalva.
I also am surprised by that.
Also, I'm still kind of stuck on the heart rate thing.
Isn't that crazy? Yeah. It's like just chilling, constant heart rate. Okay, so we'll finish up this section.
Before you go too long, we did have a patient with a cardiac transplant 10 years ago. We were still at the vein. I don't remember how she delivered, but she did very well in the 2 pregnancies she had after her transplant.
Amazing. I hope she was part of the database. So we're going to finish up this section with lung transplant specifics. The most common indication for patients to receive a lung transplant is cystic fibrosis until the age of COVID. Anyone who received a transplant for CF should have genetic counseling pre-pregnancy to assess the risk to their fetus. And then they should defer pregnancy for at least 2 years, which differs from other solid organ recommendations. And that's because of their risk of rejection and their risk of honestly dying post-transplant. The long-term effects of pregnancy on pulmonary allograft function remain unclear, and studies are small with conflicting data, as this is a pretty rare occurrence. It's good to know that pulmonary infection postpartum is common, and it affects about 1 in 5 pregnancies postpartum. So be vigilant for that if you take care of a lung transplant patient. And then lung transplant patients, as we reviewed previously, have one of the highest overall rates of rejection. So it's not surprising that they also have the highest rate of acute rejection during pregnancy, and this is estimated at about 13%. That's here. So this is their rate of rejection. And then we reviewed, there's just not a ton of data on them in pregnancy, so sort of take these numbers as you will. So the last section is just to briefly touch on the management of immunosuppressive therapy during lactation, and then on contraception. So this is a chart reviewing some of the same immunosuppression medications we discussed earlier. Like many medications in lactation, information is very limited. There is good evidence to support the safety of steroids, azathioprine, and calcineurin inhibitors. For mycophenolate, data in the NTPRI identified 7 infants who were breastfed while mothers were taking mycophenolate, and no adverse reactions were reported in the infants. But it is important to note that use during lactation is not recommended on the product labeling.
You said 7?
7 infants were reported without any bad outcomes. For sirolimus and everolimus, there are only case reports available, but no adverse neonatal events have been reported. So it's sort of a discussion you can have with your patient. I learned a bit about contraception too that I really did not know. So this table displays the current US MEC medical eligibility criteria for contraceptive use in pregnants with uncomplicated and complicated solid organ transplant. So a complicated solid organ transplant is that which is affected by graft rejection or allograft vasculopathy, which can be a sign of graft rejection. The American Society of Transplantation does not endorse initiation of IUDs in complicated post-transplant patients. Interesting. The first concern is surrounding the possibility of decreased effectiveness of the IUD, specifically the copper IUD, because its mechanism of action relies on local inflammation that may be decreased by the patient's immunosuppressive regimen. Robust data is really lacking in this patient population, but if you look at IUD failure rates in a similarly immunosuppressed population like patients with HIV, there is no decreased IUD failure rate. So, question mark. The AST, the American Society of Transplant consensus guidelines, also cite concern for infection risk in their recommendation against initiation of IUD use in the setting of a transplant. In all existing large case series examining levonorgestrel IUDs in solid organ transplant patients, no cases of pelvic inflammatory disease have been reported. And then studies on copper IUDs in HIV patients found equivalent rates of IUD complications, including PID in HIV infected and non-infected patients, which you can argue is like an equivalent immunosuppressed population. Continuation of IUDs already in place is thought to be safer because the highest rate of pelvic infection is immediately after IUD placement, with infection about 6 times more likely in the first 20 days post-placement compared to 3 weeks or more later. So like all things in the realm of contraception and family planning, it is important to weigh the risks of an undesired pregnancy against the risk of a pelvic infection in this patient population. And don't give them anything with estrogen. Okay, this is my summary slide.
Oh my God, I love it.
Patients are at risk for both maternal and fetal adverse outcomes. Graft function preconception is directly related to risk of graft complications, intrapartum and postpartum. Patients considering pregnancy should have preconception counseling with MFM, genetics, and transplant specialists. Intrapartum monitoring of graft function is highly organ specific and best accomplished with your multidisciplinary team. Delivery planning should involve transplant surgery, organ-specific medical subspecialists, and anesthesiologists to provide the best care possible. And then every patient should be given information on how to enroll in the national or international pregnancy and transplant registries that are available to them. There are literally so many things out there. A lot of sources. That's it.
So great.
Ah.
I was about 1,000 screenshots.
This is an amazing,
Yeah, please do.
Dr. Green, this is an amazing presentation.
Thank you so much.
Yeah, it's really great.
As a MFM lecture, basically.
Yeah, well done, well done.
Really well done.
Yeah, so much to
See
do.
many kidney, livers, and not see, I mean, I don't know if you saw it, we reported 8 intestinal
I
transplant.
couldn't even get into intestinal. I was gonna add like so much
that
time
have
to
been
this.
done. So you see all kinds, and there are more and more
Mhm.
transplants being done. But if they start, obviously, your point is if they start healthy, like kidney with a normal creatinine and kidney function, liver, good immunosuppression, change and everything. Tacrolimus. Again, I've been doing this for a while. Before tacrolimus was more complex, they were on CellCept and, Michael, things that were
CellCept, yeah.
probably safe. And now tacrolimus, they do really well. I know that they say to follow all those, it's even in my book and think, follow the levels. I mean, you increase it, like you say, the 20-30%, and they usually do okay. But, and I haven't seen, tons of transplants. I haven't seen there many rejections,
I mean,
hopefully more people get in and they're fine. It's been a year or two. And
yeah, I think I mentioned early on, the most likely outcome is a good outcome in transplant. But that's also because most of these patients are health aware, highly educated because they've been forced to go through the medical system. And they understand that the graft function going in is the most important predictive factor. So most people,
Yeah, well done, excellent.
I love that you talked about, I love that you talked also a little bit about with the use of NIPT. Aside from potential sex discrepancy based off of the donor, possibly being male, female, something else to consider too is what lab you would send your NIPT to. Definitely, I can see a SNP-based platform used by Natera also being problematic. And that's why also they will ask those questions about like, has your patient ever had any, transplant or blood transfusions for that exact reason? I know we had that beta thal case too, where this kind of came up.
So I think Katie is going to review some blurbs.
patient.
Yeah.